Cholesterol is a lipid actually, and cholesterol, we go in from biochemistry. It is a combination of lipid and proteins, right? Lipids which incorporate with the proteins into the liver. They synthesize into the liver, and there are two types mainly cholesterol, HDL and non-HDL cholesterol. The HDL cholesterol is also called as good cholesterol because it reverse transport the cholesterol from the vessel and to the livers for excretion and recycle. While the bad cholesterol, it transport the lipids from the liver to the vessels. That vessel might be coronary artery, common carotid artery, or carotid arteries in the neck vessels, or any peripheral vessels. That leads their depositions into the vessel walls, and that forms the atheroma and blockage in that vessels. That this is the LDL cholesterol. Good cholesterol is it also called as reverse transporter because it transport the lipid from the vessel to the liver, and the more the HDL, that is good cholesterol, the lesser the risk of atherosclerosis and atherosclerosis coronary artery disease and atherosclerosis coronary vascular disease. That's why it is beneficial. It reduces the risk of heart attack and other strokes and peripheral arterial disease. That's why it is called as good cholesterol. And bad cholesterol, because it deposits into the vessels and it leads to the stroke, myocardial infarction, we call it as a heart attack and peripheral arterial diseases. Therefore, it is called as bad cholesterol. It is actually a level of LDL cholesterol which varies from person to person. Normally, it is LDL level around 100 mg per DL, considered to be normal. If the patient is having the high risk factors like diabetes, hypertension, obesity, smoker, alcoholic, then we ask to keep the level around 70 mg per DL. The patient is having atherosclerotic coronary artery disease, CAT disease, or stroke, and then the level is a recommended level of LDL cholesterol is 55 mg per DL. Now, research is also ongoing to reduce the LDL cholesterol till the 30 mg per DL. We call it as lower the better and earlier the better. The lower the LDL cholesterol, it will be better. How much earlier we reduce it, it will be better. So this is not a one single terms I can dictate you, but it is a range. It varies from person to persons, and it depends upon the patient's profiles. High cholesterol actually manifest into the form of the disease. It is a reason of a pathology and pathophysiology into the vessels. It may deposit into coronary artery. It may deposit into the carotid arteries in the neck vessels, may deposit into peripheral vessels like femoral artery or anterior tibial popliteal artery, where it can lead to peripheral artery disease. So it manifests into the symptoms like if deposit into the coronary, present with CAD, coronary artery disease, present with MI, heart attack, STEMI, non-STEMI, unstable angina. Or if it deposit into carotid vessels, it present with stroke. Patient may present with hemiparesis and facial deviation. If it deposit into the peripheral arterial disease, or it leads to the PAD, we call it PAD, peripheral artery disease. It present with claudications and limb ischemia and gangrenals. First thing is that obesity. If you are obese, that means that there is increased level of TG, triglyceride, LDL level, and we should check it. The second one is you having the symptoms like chest pain, claudications, dizziness, and third one is we can check by the physician actually detect it by having xanthelisma and xanthoma. These are the lipid deposit into the skin. It gives yellowish discoloration over the eyelids, and by which we can identify there is hypertriglyceridemia and dyslipidemia. The major concern is when a patient is obese. It means we have to check lipid profile. The obesity is the sign. First, they have to do the cholesterol level. We call it complete lipid profile, which include the LDL, VLDL, HDL, triglyceride levels, and then they have to visit the cardiologist. They classify the patients. They will ask them the risk factors like obesity, DM, diabetes mellitus, hypertension, obstructive sleep apnea. The obstructive sleep apnea is nothing but a patient who snores during sleeps, and we And then we classify and diagnose it as OSA. The patient is having smoking history, tobacco addiction, alcoholic. This patient should visit the doctors with their lipid profiles. And then cardiologist calculate their atherosclerotic risk. We calculate it as ASVD risk calculator. If there is a low risk, intermediate risk, and high risk. If it is high risk, then we have to treat it. The high cholesterol level, once we identify that the patient is having a high risk atherosclerotic risk or high risk ASVD risk, then we go for the statins. It contain atorvastatin or rosuvastatins. Then we, according to the guidelines, we further add the ezetimibe, and then the PCSK9 inhibitors, which are new molecules and expensive molecules like alirocumab and nivolumab, which use for the reduction of the cholesterol, to treat the cholesterol. There again one new molecule, inclisiran, which we now using to reduce the cholesterol levels. The patient is asymptomatic and having no risk factor like diabetes, hypertension, obesity, obstructive sleep apnea, and smoking, alcohol history. Then we advise 5-yearly LDL lipid profile. If the patient is having high risk profile, or patient is having some disease, cardiac disease, and stroke and peripheral artery disease, then they have to check it yearly. Main treatment of the hypercholesterolemia is the lifestyle changes and diet. Diet includes low carb. It is not only just sugar free, but caloric index of the diet should be low, and low carbohydrate diet, low fat diet, and daily exercise. Daily 10 to 15 minute exercise, aerobic exercise is better. And diet include fibers, legumes. This proportion should be more in diet, and lower the fat and oil and sweets. That will be helpful to reduce the cholesterol level.